Hello, everyone. Can you hear me okay? We're just waiting for a few people's audio to connect and then we can get started. Sorry for being a little delayed today. Had some issues with trying to make sure you could see me. See, we're good. Okay. I think the person's having a harder time getting their audio to connect, but so in general, I'll get started. We're working on, I was going to talk to you guys about GERD today, or gastroesophageal reflux disease, and reflux basically. So pretty common, and I think a lot of people have gone through episodes, especially if they've come to see me, with having this occur. And typically, GERD is actually having reflux or acid contacts and gastric contacts from the stomach going up into the esophagus when it shouldn't. The stomach actually has an opening that's meets right around the diaphragm that goes up into the esophagus. So when food comes down the tube and goes into the stomach, that opening is called the lower esophageal sphincter, is supposed to close and keep food and gastric contacts in there. And it just opens transiently to let food come down. There is normal amount of reflux that occurs for people where it just has a little bit of opening and stuff comes up. And that's actually not an abnormal physiology. But when it's becoming troublesome or bothersome and causing damage to the esophagus, that's when GERD or reflux becomes something that we should actually look at more closely and treat in some form. Excuse me. I do have a little bit of a cold residual, so please forgive that. In general, most of the times we're either going to know it due to the symptoms of reflux, which is like a burning sensation in the esophagus, a heartburn kind of sensation at times. Some people will actually have reflux of gastric contacts going up into the mouth. Some people will have a hard time with hoarseness of their voice, or a chronic cough without having upper respiratory issues. Those are the kind of like the most common things. Some people will have asthma type of reactions or asthma exacerbations. And that and the cough is actually due to those gastric contacts, or even the basically the fumes from the gastric acid coming up and getting inhaled into the lung region. So that causes like either a cough or asthma wheezing gets exacerbated at that point. Excuse me. Some other signs that somebody might notice, like if you go to the dentist and they let you know that you're having issues with enamel on your teeth, if that's wearing away, sometimes that can also be due to reflux, because the acid will get up into the oral cavity and reduce the enamel on the teeth. Chronic sinusitis, like sinus infections, aggravation in the sinuses, can be due to that too, because sinuses are connected all the way through, from mouth sinuses all the way down to stomach and intestinal tract down to the rectum. So that's all one big tube. And so if you're having aggravation, that can actually not just stop at the oral cavity, sometimes it'll actually flux back up into the sinuses or cause that same kind of fume exposure to the mucosa and causes inflammation. Recurrent ear infections can occur because of it. Same thing, ears are connected down into the throat by the eustachian tube. So when we have ear pressure or inflammation or pain, sometimes that actually can also be due to reflux causing pain in this or inflammation in this tube. And that inflammation actually translates up. And then oftentimes for people with reflux, that might be significant and disturb sleep. So people often recognize if they're eating too close to bed or if they're eating certain types of foods, they'll not be able to lay down shortly after eating. Usually it takes 2 to 3 hours afterwards for people to be able to lay down flat or even partially to avoid reflux from occurring. So it often can disturb sleep and it can cause some apnea issues as well for a few different reasons actually in that aspect. One of the ways we determine if somebody has reflux is either just with symptoms that they're talking about or signs, like I was talking about the gastric enamel or the enamel on the teeth from the gastric exposure getting worn away. And the other way is actually doing endoscopy with a gastroenteritis or gastroenterologist. Sorry, if somebody has their you guys can mute yourselves just in case for background exposure. That'd be helpful because it bounces through. So the endoscopy is done by a gastroenterologist to see if there's actually exposure of the esophagus to gastric acid. And so they can see if there's inflammation or ulcerations occurring. They can see if there's Barrett's esophagus, which is also related to reflux. And they can also grade like the amount of damage that might be occurring. And when they do that, they also look at stomach and the lining of the stomach to see if there's any ulcerations or aggravation that's caused inside the stomach lining. One other thing that people will often find they have, and sometimes either a gastroenterologist or a ear, nose, throat specialist might find this. It's called LPR, which is where like the hoarseness of the voice comes in sometimes, or loss of voice. So the laryngopharyngeal reflux. So the larynx is the voice box and the pharynx is the throat. I don't have reflux, but I do have a cold. Anyway, so that is actually found, and an ear, nose, throat specialist might be able to also look at that with a, they do a short scope. So they go through a scope that only goes down to the voice box versus an endoscopy with a gastroenterologist will go all the way down to and through the stomach and into the first portion of the small intestine. So some of the pieces, some other signs or symptoms that people might experience is the constant throat clearing, kind of like what I've been doing, that chronic cough or sore throat, bad breath, because you're constantly having exposure to the gastric acid or the gastric contents, and that's also coming up. So there's also a change in the mucosa of the esophagus and into the oral cavity as well. Sometimes bacterial levels might change and types might change, both in the mucosa of the esophagus and the stomach, but also in the mouth. A sensation that you always have something in your throat, like it's hard to swallow. Aspiration pneumonia can be recurrent for some people. And spasms of the larynx can occur at the same time. So part of the question at that point is what can we do when it's happening? So the major first piece that I would look at is, why is it happening? Like, what could be the underlying cause of it? I do obviously always want to help treat symptoms and to help get it under control, but we always want to know why it's happening. Some causes for it are either obesity can cause that because the extra intra-abdominal pressure, so like lower abdominal pressure, like obesity and pregnancy, where we're actually having extra weight or a baby in there pushing up, will push up on the stomach, which also pushes the stomach up through that diaphragm, which I was talking about earlier. So bottom of the lungs, here's your lungs. Bottom of the lungs has the diaphragm, which is a muscle that's automatic muscle. It's called a autonomic muscle. And underneath that is the stomach here. And so in through there, there's a hole in the diaphragm that allows the stomach and the esophagus up from the stomach to go up through. And then that actually kind of holds the stomach there. So when there's too much pressure underneath pushing, the stomach will actually get pushed up through the diaphragm. And that allows that lower esophageal sphincter to open more readily. It doesn't close as readily. And so reflux can occur because of that. Same thing can happen similarly if somebody's working out excessively and doing a lot of lifting, or even with work situations when people are lifting heavy objects consistently. Anytime we hold our breath when we're doing like a major lift or a crunch, like when people do stomach crunches, for instance, anytime we do those kind of things and we're holding our breath, we're actually like increasing intra-abdominal pressure, which means pressure inside the abdomen. And that actually will do the same thing. It pushes the stomach up into the diaphragm and sometimes past it. In general, even that mechanism can push contents of the stomach up through. So being conscious of like when we last ate, how much we ate, can be a big factor in that as well. Overeating can be an issue for that because our stomach only holds so much, can only process so much through at once. Sometimes reflux occurs naturally because of that, without any of these other pieces on board. As it's mixing and pushing things through, it's actually gonna, every once in a while, that sphincter will open and allow a little bit of reflux to occur. Some of the aspects, sometimes medications can cause this or allow this to happen. Smooth muscle relaxants can cause that to occur because it allows the esophageal sphincter to open more readily or stay open and not close fully. There are head injuries and things like that that can also allow it to occur because it's interfering with nervous system function. And even high progesterone states for women. If we're in a high progesterone state or we take extra progesterone to help balance us back out, some of us might notice that that actually causes that same thing because it is a smooth muscle relaxant. And so it has that similar impact. Some of the things we can do to help reduce that, obviously, is either, have your baby losing some abdominal weight, being conscious of how we exercise and lift by breathing out when we're doing the crunch or doing lifting, making sure that we're not breath holding. Excuse me. And then foods that we choose. There's a lot of different foods. Like when you think of even heartburn, heartburn's not the same necessarily as reflux, but sometimes they're associated together. And the same foods, similar foods can have impact. So sorry for the acronym, but it's called Cut Out the Crap, CRAP. And it was taught to me by one of my mentors years and years ago. But some of it is cigarettes, extra heavy carb foods, smooth muscle relaxants are for smooth muscle relaxants, extra abdominal adiposity or intra-abdominal pressure. And then also making sure like pain medications and things like that, like NSAIDs can actually cause aggravation to the GI tract, and especially in the mucosa of the gastric area. So that can be an issue for that as well. Spicy foods are an issue for a lot of people, acidic foods. Those are things that we can kind of just pay attention to as far as diet or lifestyle, which actually can also reduce the reflux without even needing medications. And that's kind of the goal. My goal first would always be to try to have that. If you haven't tried that first, those are always things that people should really like kind of look at trying to get underway, because you can put as many medications on board, or as a lot of the medications are either PPIs, proton pump inhibitors, or H2 blockers. So like Prilosec, omeprazole, Zantac or Pepcid. Those all are used often for this. And as are like Tums and baking soda relief and things like that. You can put as many of those you want on board, but if we don't fix the underlying causes or reasons, then we're just going to still typically override those medications and still have that problem and still have those symptoms. There's only so much a medication can do when there's still an underlying issue. So in our realm, or in my realm, I would prefer to always work on lifestyle. There are other supplemental supports, a lot of mucosal supports that actually keep damage from occurring when it happens, or helping to heal the gastric tissue. Part of the concern with reflux, aside from, dental erosion, lung exposure, voice box, larynx exposure and damage, which can be reversed to some extent for some of these, but not always. If you have the enamel wear off on your teeth from it, you can't just get enamel back. Some of the damage to larynx is not always reversible that I've seen. But the other concern is if it develops into something called Barrett's esophagus. And so Barrett's is a change of the tissue in the esophagus right at the juncture of the stomach and the esophagus. So right here, where that juncture changes, so the esophageal sphincter is here, and that area above that, the tissue, because of exposure to gastric acid and some of the other contents like pepsin and everything that's in the stomach, those tissues start to change. And they can actually become cancerous over time. And so that is part of the concern and a lot of reasons why focusing on underlying factors and keeping damage from occurring and then healing that as much as possible is really, really important. Not everybody will develop Barrett's esophagus, but it is a risk. And sometimes it seems to run in families. And so that's either because reflux or other underlying causes for reflux might run in families, or if there's some type of genetic predisposition, we don't really have that answer yet. Let's see. Some of the other times, which I did not mention yet, that reflux can occur is when people are constipated and they're bearing down. So that other intra-abdominal pressure where you're breath holding, bearing down, lifting, those kind of pieces can actually cause that. So when people have chronic or even transient constipation, sometimes we'll get reflux that occurs because of that. The more often we are putting pressure against the diaphragm with the stomach or the other organs and pressure inside the abdomen upward, the more likely the diaphragm's going to kind of give way a little bit over time to become that's its norm anymore. So it's not as tight of a structure to hold the stomach in place and keep it down. So, resolving constipation or making sure you're breathing out when you're pressing, trying to get stool to pass is always like one of the other factors that we can look at. SIBO or SIBO, small intestine bacterial overgrowth, and even fungal overgrowth of the intestinal tract can also add to this. Often causes distension and bloating of the abdomen. Both of those often do. It's part of the symptom picture. Changes the microbiome and it changes enzyme function. But that pressure also does the same thing as having extra abdominal pressure. It pushes the stomach up and it causes that lower esophageal sphincter to relax and allow acid to reflux up. Let's see. So some people are never sure whether, there's always the question, and when you look online, there's always a question like, do I have too much acid, not enough acid? The thought process has been before like, well, maybe it's just too much acid all the time. So a lot of people will try to do baking soda or Tums or like the PPIs and the H2 blockers to actually reduce acid production. which definitely keeps you from having acid reflux up into the esophagus and cause damage. It doesn't mean that contents aren't refluxing still. It just keeps it from having the acid itself doing it versus and the burning from changing it. Part of the issue with that is if we're reducing hydrochloric acid, then we're also reducing digestive function. It is known that those medications will actually reduce the ability to break down proteins. So hydrochloric acid often is one of the first steps in breaking down protein after we chew and swallow our food and get that process going. Hydrochloric acid is one of the first steps in the stomach that actually helps to break down protein. If we reduce that, we're not digesting well, tend to have a little bit more bloating and distension and gas because of that. Sometimes we'll have indigestion or constipation because of that also, because we're not digesting really well, which also means if we're not breaking it down well, we're not absorbing it well. And so from that, hydrochloric acid is the one thing that can actually break apart red meats and release in other areas like eggs and things like that that have B vitamins. Hydrochloric acid is needed to break that apart and make that available for our body. So people tend to get B vitamin deficiencies if they are taking those medications. It also has significant impact on bone health over time. So it's known that because of those, they actually can cause osteopenia and osteoporosis to occur over time. And so it's super important to me when I see someone that's been on it for a long term. And especially if we're getting into, older stages, anywhere after 30, in all honesty, we start losing muscle density. Typically, if we're not using it, we tend to lose it. And we lose bone density at that same time as we age. Women, especially, because as we age, we start to lose estrogen, more so closer into your 40s and on, of course. And that impacts bone density as well. So when we're having that on board, I always try to find out other ways to help support the person to get that under control, to get those medications out. Originally, when the medications were being prescribed, and even now, they're supposed to be used for a temporary use of 6 to 8 or 6 to 12 weeks. And that's not how most of them are used at this point. They definitely can be helpful in short term, especially with symptom management and to keep other damage from occurring, because Barrett's esophagus is a real issue, and so are some of these other issues that we were talking about. But if we can also work on the underlying causes and fix that aspect and get it resolved, then we don't need those. I will say also that there are incidents of people having reflux without symptoms. It's called non-erosive reflux. It's called NERD, actually, N-E-R-D. And so people can actually have reflux without having major damage occurring, or at least at that stage, it's not occurring. Some of the things that we use for, like in the naturopathic realm, for help and support, at least in a more herbal sense, is mucilaginous herbs to help coat. It creates a mucus reaction, or themselves actually have like a mucus substance from them. So marshmallow, aloe, slippery elm, those kind of things are actually mucilaginous. And when we use those, it's actually help coat and soothe the esophagus and the stomach, which can actually be beneficial and help with symptom management and also with actually tissue healing. One thing we often want to check just in case with reflux, although it's not always the same occurrence, is just to make sure there's no H. pylori overgrowth or ulcerations in the stomach or the small intestine, and just the first portion of the small intestine. And, they check with that with the endoscopy. They can check H. pylori, which is Helicobacter pylori. It's a bacteria that's actually normal in our gut. But if it is overgrown, which can occur with keeping the acid 2 reduced, then you can actually end up with ulcerations. Ulcerations in the stomach are often caused by H. pylori. The overgrowth of that is what actually causes that to happen. So checking to make sure that that's not on board, because you can also have some similar symptoms with like burping and reflux that occur, distension in the abdomen. So make sure that's not on board, or if it is, just to treat it may also help reduce symptoms in general. See. There's so many other pieces to it, but I want to make sure I'm not going over like time or over people's heads without actually having people be able to ask some questions. So I think right now, just in case, if you have questions, you're more than welcome to either like unmute yourself or send me a chat. Probably unmuting yourself and just asking the question is best so that we can actually, have that on the recording for later if you're open to that. Please feel free to like ask away, knowing that I can't give you specific dosing or anything like that, but I'm happy to like answer questions or add more to it.
Hi, Misty. This is Astrid.
Hi, Astrid. I see you there. How are you?
I'm great. Thank you.
Good.
So I don't have this issue, but my husband does. He had the X-ray or whatever you call it, the endoscopy and whatever you call that. Where they go down, and they took a picture, and he has the faulty valve, which is genetic. And the doctors have prescribed omeprazole long-term. So he takes 40 milligrams a day long-term. And I'm wondering about your thoughts on how how long-term, omeprazole can affect softening the heart muscles, or like what the risks are of long-term medication. Thanks.
You're welcome. Yeah. So as far as heart muscle, I don't know of a direct connection except for, I'm trying to think if there's a back reason for, I don't know one specifically, except for nutrient deficiencies. So anytime we're using omeprazole or, the PPI or the H2 blockers, omeprazole is actually a PPI. We can have and often do have nutrient deficiencies. So in that aspect, that can impact heart and maybe end up leading to some complications. The biggest thing over time, like I was saying earlier, is one, having issues with absorbing calcium for bone health. Calcium and vitamin D are needed for bone health along with many other minerals, but if we're not breaking foods down appropriately, we're not actually able to absorb them well. And so over time, bone health suffers, and that's both male and female. Those are the biggest issues with that. There's other options, and same thing is what they're trying to do is they're trying to protect the tissue. So he might be able to consider other options, especially if he's got a gastro on board. He might be able to do some other naturopathic type options and see like between endoscopies if he's maintaining tissue health. So the big thing is like they're looking at protecting the esophagus from erosion or Barrett's from developing if he doesn't already have anything like that. So he could do that as an option as long as they're willing to repeat the endoscopy and make sure that he's not getting erosions that happen. They probably would not be agreeable to it, but those are options for him to look at and to look into versus the complications that can develop for long-term use of a PPI.
Excellent. Thank you.
You're welcome. You're welcome. Yeah, the only other piece I would say is I would advise actually like that he could try to do is to talk to his doctor or two about any of those side effects and what he could do to minimize those, like whether he should be doing any other kind of supplements to help mitigate the possible nutrient loss. Yeah. Anybody else have other questions? Not yet. I will say there's a couple other studies that came up. I just had my conference. I'm part of the Gastroesophageal of Naturopathic Physicians, and we just did our conference this last weekend. And one of my previous mentors brought forward some studies that came up. We're just talking about different types of adiposity or fat mass. So like when we, gain weight in certain areas, usually abdominal adiposity versus call it pear-shaped versus apple-shaped versus like on hips and buttocks. The fat deposition on hips and buttocks is usually less detrimental for or less cause of reflux type symptoms, in addition to cardiovascular risk. So the apple shape where it's mostly in the belly, and I know you guys can't see my hands because I keep doing hand shapes, but the deposition in the belly region is more risky for like causing like functional mechanical reflux to occur, and also for cardiovascular risk. So and diabetes, there's more risk for that with the abdominal adiposity. Let's see, another notes. So some of the medications, I didn't give you a list yet of those. Some of the medications that can cause or instigate GERD are some antibiotics like tetracycline, bisphosphonates, which are actually for osteoporosis. So something, one called Fosamax or Beniva and Actonel. Those are all bisphosphonates. They actually are used to try to help increase bone density. But in the meantime, that can actually cause a GERD. And so in the meantime, a lot of times people end up on PPIs because of that, or already put on one when they're using this medication. So it kind of causes osteoporosis, but it's the same to using a medication to try to fix the osteoporosis. So, and those have pretty significant side effects. Iron supplements can also have similar effects. Like I said earlier, pain relievers like ibuprofen or aspirin, the NSAID families are aggravators for GERD. Potassium supplements, because it can be like a smooth muscle relaxant also, and progesterone. And then sedatives or tranquilizers like benzodiazepines and sleep aids can also do a similar activity because it impacts the nervous system function. And one of the things I think I started talking about a little bit was am I too acidic? Am I too low acid? There's pH testing that can be done typically through the gastroenteritis or gastroenterologist office. Oh my goodness. And they can do a pH test, usually with a pill that is put down. And there's some new tests too, new and older tests where you actually like kind of swallow down a pill that sits right above the stomach to actually measure pH, which is whether you have enough acid or low acid. If it's hyperchlorhydric, which is high acid, then sometimes we just want to be able to like use things to reduce that to some extent. If it's low acid, that lower esophageal sphincter usually uses a pH measure. So it knows like when it hits a certain pH, when it gets more acidic in the stomach, it will try to close. If we have too low of acid, it doesn't always close. It needs that higher acidity to signal it to close. And so low acid can be part of that. So sometimes we actually will use hydrochloric acid like ox bile and hydrochloric acid, betaine, hydrochloride. to actually help stimulate that, and then also help with digestive function of the foods that you're eating. So some of the other things that we were talking about earlier, I forgot to mention sodas or colas. Anything with a lot of carbonation can actually add to that, because those bubbles create more pressure and causes the sphincter to open. So if there's other contents in there at the same time, that will actually allow more to come up. Chocolate, unfortunately, which is my downfall. That's one of them. Eating too quickly and not being in a relaxed state when you're eating, because digestive function kind of shuts down. That's my big piece is I always want to talk about sympathetic versus parasympathetic activity when we're eating. If we're not in a relaxed state, a parasympathetic state, we don't digest well. Digestion just gets put on hold saying, no, we're too anxious. We have to do something. We have to run from the tiger. We don't have time to digest. So if we're not actually in this relaxed state, we don't digest well. So food will tend to sit in the stomach longer. And rapid eating is part of that. A lot of times when we're just shoving food in, we're very unconscious of what we're putting into our body. And so digestive function, the enzymes, the acid, all the pieces that needs to get released for digestion to occur, don't get signaled. So if we're not like looking at our food ahead of time, preparing our food, getting hungry or being hungry for our food, sitting down and being conscious of our meal versus watching a show or, talking rapidly with somebody else while you're trying to engage in this really fast conversation or being stressed during a meal. Those are kind of things that can actually add to reflux occurring because we're not going to be digesting well. Snacking in between meals. Meals should really optimally be farther apart from like each other versus like constantly having food going in, not being allowing our system to have time to like digest and then move that through and then do this cleansing wave that usually can actually help with cleaning down, pushing down debris and bacteria, towards the rectum. That usually only happens in a fasted state between meals, like 3 to 4 hours apart at least. And so if we're constantly snacking, those movements of the GI tract are not occurring as they should. Yeah, like I said, just spicy food or foods that we're really sensitive to can be part of an issue with reflux. So sometimes when we do food intolerance testing or just dietary eliminations, it's usually in trials to see if that's actually helping. If we have foods that we're either allergic to or sensitive to, we're going to get an inflammatory response. And that's not going to, that's actually just going to increase the likelihood that reflux is going to occur. So let's see. So just as a list of some of the things that we use in our realm for support, DGL or deglycerinated licorice is one. It coats, it's one of those demulcent herbs that I was talking about, the mucilaginous type herbs. It helps to coat the esophagus and the stomach and to protect it. Zinc carnosine is another. So people typically often have been taking zinc a lot, especially with COVID. At the onset, people started really learning about how much zinc can actually promote immune function. And then zinc carnosine is actually a specific type that actually helps to heal interstitial spaces or leaky gut, so to speak, intestinal permeability. So we can have that in the esophagus and in the stomach too, where the cells between each cell of the gut or the esophagus actually have had so much inflammation or reaction occurring near there that the junction between the two actually splits apart. So then we have more relation between what's going on in our gut and what goes into the bloodstream in the body. And that's not supposed to occur. So we have more immune responses to that. And so that zinc carnosine along with L-glutamine and some of these other demulcent herbs, actually helps to heal that juncture and reset it so that we're not having so many reactions. So that takes time, depending on how long that's been present, to actually heal that up. But it definitely can heal and kind of reset the stage for you. So aloe vera is another one we've used plenty of times. And then something called NAG, or N-acetylglucosamine, actually helps repair damage to the lining for the esophagus and the gastric mucosa. Other pieces. Curcumin is always one. I don't know if you guys are familiar with curcumin or turmeric. It's very anti-inflammatory. And so that can actually be really helpful with reducing inflammation and helping healing. It usually is best if it actually can be in contact with the gastric mucosa. So we usually take it in capsules. You can also do it in like honey milk, honey teas. That's how it's often drank. It's put in soups and things like that often also. So as food is medicine, that can be an aspect that can be helpful in general with reducing the inflammatory response that's going on. And let's see, melatonin is another. There's a little bit of controversy right now with melatonin, again, wondering whether it's protective or if it actually can have, I mean, it's been shown to be protective for a lot of different things. It actually seems to be helpful with resetting the reaction to like reduce GERD, and helps reset the mucosal membrane also. It's very antioxidant in higher doses. And so there's definitely benefits towards it. Usually in doses up to about 10 milligrams, people are finding sleep support if they need sleep support. Above that is usually what's used more often for other chronic illnesses or cancer care. It's used often also. So if somebody's already on it, that's really helpful. I think so. There's a couple pieces that help, because when I talked about like GERD being part of like having stuff sit in your stomach too long or in your digestive system too long. If there's MPACs that are like, I don't have enough enzyme capacity right now, some people just do for other reasons, or I have gastric emptying issues. Sometimes that's on board with diabetes. Sometimes it's from SIBO or other overgrowth and infections. It's due to medications often. Opioids and things like that too for pain meds also do this directly. That food sitting in there and being delayed, we can actually help move that through with prokinetics. So ginger is my favorite, like base prokinetic, because it's basically food based. We eat it already. If you actually have it in doses that are strong enough to actually create what's called a prokinetic effect or a movement effect, it helps to move things through the GI tract and get them moving down. Ginger is also anti-nausea. It actually is a really good digestive, carminative and digestive aid. I guess it stimulates a few different areas of the digestive process. Artichoke is another. And there's multiple other medications that have a combination of ginger and bitter herbs and things like that. So often I will either use that or bitters to get people started in general for getting digestion on board and getting things moving. One of the big pieces, which I did not mention yet, is hiatal hernia. So hiatal hernia is actually what I was saying earlier about where the stomach moves up through the diaphragm. So your diaphragm, stomach, and it starts to move up through. If the stomach gets stuck above there or comes back and forth, it's called a hiatal hernia or a sliding hiatal hernia. So sometimes surgery is done, but not usually until it's like an extreme situation, because surgeries aren't always fixing all the underlying issues, and can complicate things. But we can also do exercises that actually help to strengthen that diaphragm around the stomach, and also just physically be able to try to pull the stomach down to some extent. There's a number of naturopaths and chiropractors, and maybe even functional med doctors that actually do this quite a bit. And it's just called hiatal hernia maneuver. And then there's exercises, like I said, that actually help to like maintain that and reduce that to some extent. And even manipulation in the GI tract of like stomach, pulling stomach literally down. One of the other pieces that can actually help if there's too much acid, there's not a lot of things that I know of to actually reduce hyperchlorhydria, the excess acid that can happen. But alkaline water, you see it a lot more in the stores now, which is like a higher pH water. It's usually like 8 or above, helps to reduce acid levels in the stomach by reducing pepsin, which helps to release that. So it buffers the stomach acid. So that's an option to actually do if you actually know you have high acid in the stomach. Let's see. Astrid, one of the other things to have maybe your husband look at too, just in addition, is like thinking about high oxidative foods. So like dark leafy greens, berries, really like dark colored and brightly colored fruits and veg are really highly antioxidant. So anything like that, just to increase as food base for helping to support or reduce risk of Barrett's esophagus and to reduce risk of that turning into cancer. Anytime we can increase antioxidant support, that helps reduce that risk also. Reducing inflammation, the curcumin, things like that. Green tea extract. Those are all things that actually help overall nutrient support, but also like reduce risk for changes to occur to the tissue. So I think that's kind of the big pieces I have. If you guys have other questions, I'll give you a few minutes to ask. Otherwise, we'll be closing her up. If you guys have questions, just unmute and let me know. Okay. Well, I hope that you guys all have a great day, and thank you for joining me. I appreciate your time. If you have anything that comes up later, you're welcome to contact us here at the clinic. And happy Friday to everybody. Bye.